with Amedisys that he told me about, but I've forgotten what
You're
it is.
totally fine. I'm one of the hospice liaisons. I also have a nursing background as well.
And we've been talking for days now about end of life, how to make decisions, what are your options, and one of the options that we've talked about is palliative care, and Amedisys provides palliative care.
We can chat, yeah.
And I told Michael that we would probably have some questions about that area. And of course, he's also one of the hospice teams that's providing hospice services to Bishop White Lodge and to our apartments if we decide that we don't want to be in Bishop White Lodge. I'm going to turn my mic off now and let Michael take over. Okay? We're good, Ed? Fantastic.
Thank you so much, Susan. Thank you guys for letting me be here. It's an absolute pleasure. Like Susan said, yes, my hospice team, we are over at Bishop White, and we do bring that hospice support over to the apartment side. When it comes to hospice or any added support, we can provide that support where home is, whether that's at a nursing facility, whether that is home, Bishop White side, the independent living side, wherever you call home, that's where we can certainly go to. If there is that need to transfer from one place to the next, we can certainly accommodate to that. But yeah, wherever home is, we can certainly provide that services too. So we'll go ahead and get started here. I have a few slides. If there's any questions, please yell, hey, I have a question. We want to make sure any question is answered while we're here. Perfect. All right, so we'll go over death and dying today, task elements of a good death. In the hospice world, we want to make sure every death is a good death. We don't want, there have been bad ones, but we want to make sure that the steps leading up to it is good. We want to make sure communication is there. We want to make sure that there's a plan in place. And more importantly, if there are stepping stones that are some barriers, we want to make sure that we are there to support, talk with you guys, talk with family, and make sure it is the right decision and appropriate decision to make. Some of the emotional challenges that we face when it comes to hospice services, palliative care services, or just this overall process from start to finish are the following. There's fear, there's anxiety, there's vulnerability, there's guilt, helplessness, shame, and grief. Shame, maybe not so much. We have seen it in the past, so we've kind of added it onto this slide. So a lot of these emotional factors go into the loved one that is starting to transition, also family as well. I know my grandfather has passed away when COVID kind of came out, so my family kind of went through all of these. I'm sure all of you have felt all of these feelings in your everyday life. So this is something when it comes time for that planning, when it comes time for that transition, speaking with the hospice team, speaking with the palliative team, we have our nurses, myself, I'm available, and more importantly, we have social work, we have chaplains, and we also have bereavement services after the fact for 13 months that can also help with a lot of this. We have our chaplain, Justin, who can come in to do prayers, to speak. So if that is something spiritual-wise, we can certainly accommodate too. And we want to make sure all of these, if they are at hand, we want to make sure that these are tackled. We want to make sure that these are talked about. Even if someone is not comfortable at this time, we can always be reached. We can always be contacted after the fact. This kind of statement here, we only get one chance, is very, very important to us, especially when it comes to that transitional phase. As you know, with hospice and that death, and sometimes not so much that palliative time, but we only get one chance. We only get one chance to make this right. We only get one chance to support. Not only do we get one chance to do our job, but we get one chance to support families, to support loved ones, grandkids, kids. There is only sometimes one chance. Very few do we get two chances. My son plays football, and I always tell him, you always get one chance to make that play. Football, I'm trying to even though you get 4 downs, I'm trying to get him to be a little more aggressive. But and he always comes back and go, well, Dad, there's I have 4 more times, and then we have to kick the ball away. So still working on that with him. But hospice is a little different. We only get 1 chance. So it's important through this whole entire process that if there is a plan in place, from starting to even talking to family about, hey, I want to make this palliative route, or even talking to your physician, kind of saying, hey, I've been to the hospital more times than none. I've had falls. This is something that I don't want to continue to do. Where's another step? What can I do to prevent this? What can I do to prevent these falls? What can I do? Maybe the doctor or your physician is changing medications. Every time you go in, he's like, oh, let's try this, or let's try this. Sometimes those changes also kind of alter, one's cognitive abilities, speech, anything like that. Sometimes those significant changes take a toll and start to take a toll. What we see is a lot of loved ones going back and forth to the hospital. Sometimes that trip alone, I know I get exhausted taking my kids to sports, so I can imagine someone that is not so healthy going from one place to the next, going to the hospital, being woken up by the nurses twice a night, needles, whatever, the whole 9 yards, the bells, the whistles. That alone takes a toll on one's body. Again, some of the emotional challenges, there's some common fears, there's some anxieties as well. Fear of the unknown, fear of the abandonment, suffering and pain, loss and control. A lot of these we can talk about. We can also control within that hospice realm, sometimes that palliative realm as well. There are some medications with hospice that we can kind of bring on board for any pain, anxiety. And what our teddy bear of a hospice doctor loves to do is he loves to start out on a smaller dose of medication. That way you can still function. You don't have to, have the full dose of, of a pain medication and feel kind of wonky, feel kind of weird. We want to make sure that, through this hospice stage, we want you to remain as independent as possible until, that time starts to come where more care, more support is needed. A lot of the anxiety sometimes on loved ones, what's going to happen to my loved ones, any financial concerns, burdens of the families, evaluating, what the meaning of life is. Should I have gone for treatments? Should I have went back to the hospital? A lot of these things kind of contribute to not necessarily the beginning, but more toward the end of that life, with their loved ones. Again, some of the emotional support, assisting and verbalizing those fears, those anxieties, those concerns, validating their feelings. We want to make sure that your voice is heard. We want to make sure that your wishes are heard. Again, the hospice route, palliative route, what we like to do when we do bring someone onto hospice services, we like to ask what matters most. Whether it's the Phillies game or whether it's, seeing grandkids, we want to make sure that we know what matters most to those loved ones so we can engage and, more importantly, hear their voice, hear the family's voice on what their wishes are. The big thing, we can also help clear up any misconceptions that might help issues that are not yet tackled, that are not yet talked about. Our nurses do a wonderful job. Shane is our main nurse over on Bishop White. We have 2 social workers as well. I can be some of assistance with, getting any misconceptions, any barriers to palliative care, to hospice care, any, stepping stones leading into, what do I need to do next? Do I need to talk to my physician about palliative care? How do I go about doing that? A lot of the physicians today are very receptive if you have that wish to say, hey, enough's enough. What does a palliative care route look like? What does a hospice care route look like? And they can, do a good job of sorting you to one way or the next. One of the nice things, there's no wrong answers. There's no wrong answers when it comes to palliative care. There's no wrong answers when it comes to hospice care. A lot of the palliative care starts, before that hospice care where you can have your your therapies, your treatments, everything up front. That hospice care late and the latter part, a lot of those therapies, a lot of those treatments stop. So that's kind of where this emotional support kind of comes in. If someone is very, one side or the next of, should I continue my treatment? Should I not continue my treatments? That's always a good question to ask that physician, ask that palliative team, ask that hospice team of, if I take a palliative route, what is this picture going to look like? If I take a hospice route, what is this picture going to look like? And we want to make sure that that route, that stepping stone that you're going to embark on is the right one. A lot of the stages that we see within palliative care, we see within hospice care, and sometimes we even see well before that, is that shock and denial, the anger, the bargaining, the depression, and then later on in life, whenever that may come, that acceptance. Weird enough, sometimes in the hospice realm, some more not so palliative care route, but with that hospice route, we do see a lot of depression. Whether that is something that was, thrown away in the trash can many, many years ago, but is now coming about. When it does come to that route with depression, when it does come to hospice, there are some medications that you can take. Sometimes it's that weighing that option of, is this going to work? Is this not going to work? And it's always a good question to ask that palliative team, that hospice team, or even that physician as well. We have seen loved ones experience all of these. We've seen more so family experience all of these. This is where these 5 steps can also be talked about at the very beginning. What is my anger could possibly be? What depression could I come up with? How can I cope with this acceptance when it comes time for this? We do have social work chaplains, bereavement team that can also help with this as well. So these are always a good thing, just to kind of keep in the back of your mind as well, that these do eventually creep up. Yep.
Hold on a second. For the purposes of our filming, we need to have the mics on. There, Mr. Kalk.
I'm confused, but that's because my brain is damaged. You seem to say that there's a separation between palliative care and hospice care.
Mm-hmm.
And I thought they were the same.
That is a good question. That's a very good question, actually. So there is a difference. There's sometimes a very big difference. So my 5 years of being in hospice and 10 plus years of being a nurse, the best analogy that I can give for palliative care versus hospice care is a swimming pool. Everyone knows what a swimming pool looks like. You have a shallow end and you have a deep end. Or shallow end is where you can, it's up to your knee, you can walk around. Our shallow end is going to be your palliative care, where you have that support where your feet are planted on the ground. With that palliative care, you can have a lot of all of your added supports. You can have your physical therapy, your occupational therapy, if there's any chemo, radiation, anything like that. You can still take cancer medications that is going to decrease the cancer cells, anything along those lines that is going to necessarily improve that quality of life. As you start to walk into the deeper end is where you start to lose that solid ground, and you get into that deeper end where you're using that kind of life raft. You can picture a rubber ducky, whatever you want. You're sitting on that raft where you can see the bottom, but you can't touch it. That is when that hospice support kicks in. So with that hospice team, as you get into that deeper end, those extra added treatments are usually, sometimes are not desired anymore. The patient's just kind of like, hey, I'm done with this. It's not working. I don't want to continue to do therapy. I don't want to go to a therapist and him say, hey, you have to lift these weights, Or, your physician's going to be like, hey, we've done X amount of treatments. We've done X amount of chemo. Nothing, we're at our limits with those. So you're getting into that deep end. That is where that hospice realm kicks in, where it's that actual comfort support. Usually within the hospice realm, the terminal diagnosis, whatever that may be, is within a 6-month or less period if it runs its natural course. Now, we've had some patients just blow that out of the water, and that is fine. So that is that big difference between that palliative care route. That palliative care is more at the beginning, hospice care is more at that end. So that's the best way I can describe as a swimming pool, so there are many differences. You can have, in some situations, very weird loopholes. You can kind of have palliative care with hospice, but you can't have hospice care with palliative care. To make you probably even more confused. And it's not something we do, it's part of the insurances and Medicare, and Medicare pays for all of hospice, they pay for all of palliative care, but it's like can't have your cake and eat it too sometimes.
But the medicines are the same.
Pretty much, yeah.
I think it's important to stress that in hospice, you have to give up treatment options.
Mhm.
You're electing comfort care
Yep.
only.
Yep.
Thank you.
And I think that that's the important distinction.
Mhm.
I think the idea that you have to be within 6 months of death is a little, it's the Medicare thing.
Yep.
In order for Medicare to pay that. But it's the creation of a legal system. It
Yep.
doesn't mean you're going to die within 6 months.
Absolutely.
Jimmy Carter was on hospice for 2 years,
Mhm.
and you're talking about that too. There
Yep.
are lots of examples, and I think one of the things that I said this week was, it's clear that in many instances, people who go into hospice live longer than they would have if they continued aggressive treatment,
Mhm.
and there seems to be good data on that.
Yes. Yep.
So hospice is the way to go. Swim in that pool.
So yeah, I won't mention any names, but we have 2 residents on the Bishop White side. I think one has been on our service probably going on, I want to say maybe 2 years, but it's that decline that they are still experiencing. And we actually just had a resident, again, I won't mention any names, but has actually graduated from hospice. So that's one thing, that is.
What does that mean? They died or they?
No, I probably should have cleared that up a little bit. We are having the death and dying talk, but no, she actually was, that's a good one. No, she was discharged from our hospice services. So she, the individual was doing well enough where our hospice medical doctor was like, hey, you came onto our services is not a good time, but with that support, with that care, with that extra eyes, ears, hands, you're doing very well right now. No, we're not saying that she's completely healed and, out of the neck of the woods, but that is something that also happens. We see it very frequently where death has a path set in stone and someone's like, nope, I am not going to do that. So I think there's a question over there as well, and one in the back.
Earlier you spoke about a number of issues of the contemplation of end of life. And the 2 words that rang out for me were depression, which I consider to be a normal experience, and also acceptance. As you observe so many people going through the end of life process, would you see acceptance as sort of an antidote to depression, or is there more to it?
That's a very good question. I would say maybe a little bit of both. I would say a little bit of both. I know I actually had one similar situation when I first got into hospice. I've been in hospice for about 5.5 years, where it was more so not the family's loved one that was going through the depression, but more so the actual patient himself. I won't go into any history background, but we kind of tried a couple different anxiety medications, and it just wasn't. It was doing the job, but not doing what he wanted it to do. And again, there was a lot of depression that was going on to it, a lot of anxiety, a lot of stress. That the gentleman, he had cancer, so a lot of his treatments were kind of coming to an end. He met with our social work, met with our nurses. We got him on services at an earlier kind of stage. I believe he was on for about 3 or 4 months or so before he passed away. And it wasn't up until the past probably maybe 3 or 4 weeks before this gentleman passed away. And he met with our social worker, met with our chaplain. They had a prayer. And what he did is he just started to journal over as best as he could, kind of write down stuff over the past couple years that maybe was weighing on his mind. Maybe, not necessarily, hey, I should have talked to my kids more, this or that, but just kind of just overall, just blanket kind of statements, just, him leading up to this actual death. And it was more of a personal thing that he kind of accepted. That and we kind of toward the end of everything, he kind of opened up a little more. But we saw that kind of depression kind of not necessarily go away. I won't say it went away completely, but it started to kind of take a little different route, just because that kind of acceptance came out of, okay, like this is it. This is my life. I had a wonderful life. I had a wonderful job. This is kind of where I'm headed. And it kind of cleared up a little bit. It didn't clear up altogether, but sometimes we kind of see those kind of weigh each other out a little bit. Yep, you're welcome.
How often does this happen? I had an aunt who was on hospice. They took her off all her curative type medications, and she was reborn. So she ended up, she went into a wedding, she danced with my son, she was really busy. The point is that I think the medications were things that you may have needed at some point longer term, but were making her sicker in the near term. And so once she went off the medication, she got better, and I think it was more than a year till she died. But the first 6 months after that, she was great.
Absolutely.
Is that common?
We do see it, yes. We do see, in a hospice realm, when we come in, we don't say, hey, hospice is here, you have to do whatever we say. You have to take away this medication, that medication. What we can do is we can always recommend. Sometimes if a medication is solely affecting the need for hospice, like if you have cancer and you're taking chemo medications, that will kind of go off. But sometimes, those medications that could maybe be affecting one's overall health, and that loved one's like, hey, I don't want to take these. We have seen in the past extra medications be taken away, and like you said, they kind of get that like second wind, second boost over that speed bump. So yes, we have seen that as well. Yep. Any other questions before I head on to the next one? Next slide. Absolutely.
Wait. I really appreciate your comments. I'm a retired nurse, oncology nurse, and so most of my experience is with cancer patients. But now I understand that there's a lot more people going on hospice who have dementia. And I wondered if you could speak to that and how that might be different, how the care might be different or the same.
Absolutely. Big difference. When it comes to the hospice realm, I won't go into the actual eligibility, but with that dementia care, there's usually some other things that are going on. With that dementia, the big things that we see are a lot of the daily tasks, like the brushing teeth, eating, drinking, getting dressed. A lot of those are extremely difficult. Or personal experience, my grandfather had dementia, Parkinson's, where a lot of the ADLs he was in the Army, he was a car mechanic, to the point where he just decided to just kind of do some things that were out of the ordinary. But him and my grandmother were married 65 years. And that was our first kind of, this is a little weird, where he didn't know who she was. So we see that a lot of with dementia, there's also a lot of weight loss, just because of that maybe poor intake with eating or drinking or that mobility of getting up, moving around. What we do with a lot of our dementia residents, we try not to disturb their environment too much. That, that's kind of like throwing a rock in a calm pond and just watching it ripple. So we try and find a plan and a care plan that is best for them, but not too aggressive. Sometimes, again, when you disturb just how everything is being thought of, sometimes that is just a tornado that you just incorporated into their well-being. We don't really take a lot of those medications away. There's sometimes what we use is some music therapy to kind of help as well. We have a music therapist as well, sometimes some prayer. And again, just kind of keeping that same person, the same caregiver. We have Shane as our nurse, Chantel as our CNA, and we've seen a lot of success with keeping the same staff. If we were to bring in Bob, Sally, Joe one day and Shane and Chantel the next day, it would not work. So keeping that familiar face helps as well.
I have a question related to that. Dementia usually progresses over years. And so that's related to the question, how is a dementia patient getting hospice care within 6 months of dying?
Sometimes, so that dementia one is a very tricky one sometimes, in that we see sometimes in that hospice world where that need for hospice comes way late, just because that dementia has been in play for 5, 6, 7, 8 years, where maybe they have that slight dementia, but everything else is okay. They can function, eat, anything like that. When that dementia care comes into play and that hospice care comes into play with that 6 months, it's more of a drastic decline. Just very drastic. They maybe fell and bumped their head, they went to the hospital. Or maybe they have dementia with another diagnosis, another severe diagnosis, where that severe diagnosis is now trumping that dementia care. So dementia is sometimes kind of a spinning top. Sometimes it could go forever and it be, maybe not warrant that hospice. Sometimes it could just stop on a dime and hospice is needed kind of right then and there. So yep.
Hi. Please forgive my entire understanding of hospice has to do with the English patient. And it seemed to be that the morphine, the extra morphine that he got at the end was a kindness.
Mm-hmm.
So is the question,
Is it possible that we can avail ourselves of that kindness?
We can't really do anything in the hospice world to speed anything up. That's not what we're here to do. A hospice is more of a natural. So when that morphine kind of comes into play, it's just more for comfort. And again, what our medical doctor likes to do is he likes to start out on a smaller dose, and if needed, kind of tack on a little more milligrams after that. Because we sometimes use morphine in the home where someone is very mobile. They still like to, take their walks, morning coffee, whatever. That way it controls that pain, controls the pain symptoms, but they can also be functional throughout the day. But we unfortunately can't use morphine to end that process, right then and there. Yep.
Thank you.
Yep. I think there's another, there's one over here too and one over there.
Well, I'm glad dementia was brought up, but you said you're later going to talk about qualifications for hospice care. My husband was on palliative care at home. He had dementia, and I just want to add the palliative care was just amazing. He was having physical therapists come, and my grandson was very young at that time, and he was like 2, nearly 3, and the palliative care therapist, things. So he can throw the ball to my husband and things, brought in the whole family, really. But then the palliative care team said he was ready for hospice. The hospice people came in and evaluated him and basically said that because he could sit there eating a sandwich, that he wasn't eligible for hospice care. Now, he was dead in less than a month after that.
Okay.
And I think it was really outrageous that the palliative care team's recommendations weren't accepted. So what are the rules that made it so hard?
So sometimes, I will be very honest, sometimes what we see in the hospice world, personally, you know, there is, when it kind of comes to dementia, it's a little tricky sometimes. So maybe, I'm not sure if the other hospice provider maybe saw him eating, maybe they didn't. What we like to do is we like to take a lot of things into consideration. The past medical history, if there's any weight loss. So I don't know why, if palliative care were to refer him to hospice, I don't know why they would say, hey, no go. I'm not sure why. I don't know if each, I do know sometimes that there's been some other hospice providers that have been consulted on some other residents that they found not appropriate for hospice. We've come in and said, hey, I'm not sure what happened, but this person is more than appropriate. So I don't know if it was just maybe the nurse that, sometimes the nurses that do the hospice admission, sometimes they're missing a chunk of, you know, what is really going on. But that's a good question. I'm not sure why, if palliative referred, I'm not sure why he was not brought on to hospice services. There could be a couple different factors. I mean, with dementia, it's a pretty clear-cut picture, you know, of what is going on. Maybe they didn't look up, you know, those kind of comorbidities underneath of that underlying dementia that could have maybe brought him on to hospice services. That would be my only kind of thought.
Hi. I don't know if this is the proper time to ask this or not, but it's an actual care question that I've heard from residents here. How many hours on sort of the continuum of care when a patient first goes on hospice and when they get into the dying process, how many hours of care could they expect to see from a hospice nurse?
Sure. That's a very good question. And that time frame depends. We'll take maybe someone a little more along the path of hospice as opposed to someone who maybe doesn't need as much care. With our Bishop White team, Shane is here at least 4 or 5 days a week, and Chantel, our CNA, is here every day, Monday through Friday. So on a time frame, what I can say is Chantel gets here morning time. I want to say about maybe 5:30, 6, just to bridge that morning get up, morning, routine. And I came in yesterday around noon, and she was still here. So again, that time varies. We want to make sure that when someone is on hospice, from the time we see them until 100% of that job is completed, that's the time that we're with them. It's usually very, very far in between do we see, hey, you're good to go, and we'll see you tomorrow. We want to make sure that there's always going to be something that's going to be needed to be done, whether it's feeding, cleaning up, just sitting with them and chatting. So.
Okay, I have one more question,
Sure.
And this is not really related, but have there been any changes made since Amedisys was acquired by United Health?
Not that I know of. No, we're still running. The only couple changes that we have, we've seen company-wide, we don't have to worry about it in this area, in the South. I think Tennessee and Texas, I believe, there was three of our hospice that were acquired by kind of a spinoff of United Healthcare, and then one of our home health agencies was acquired by a spinoff of Optum, United Healthcare. But in this situation, I actually just had a call last week with my vice president, our VP of our hospice, and nothing is changing. No names, no, because we went through that maybe 3-ish, 4 years ago, where we were compassionate care. We went to Amedisys, back to our grassroots Amedisys has a lot of the Western states, we have home health as well. So for right now, knock on wood, nothing is changing.
Michael, I'm gonna say no more questions.
Sure.
And let you get on with this, and then if there's more time, which I hope there will be,
Mhm.
because there are some follow-ups.
Sure. So some of the tasks of dying is getting the affairs in order, the living wills. If there's any funeral home arrangements, that's kind of falls under that play. Making the medical conditions. I think that is where that early detection between palliative and hospice care plays a good role, or even home health. Home health kind of comes between that. Before that palliative care route, they kind of go hand in hand. And planning for the immediate future, whether that is, I'm going to need hospice now, I'm going to need palliative care now. That is something that hospice team, maybe those physicians as well, can certainly help kind of gauge that route. And then last, coping with those emotions and physical changes with end of life, whether that could be going from an independent living apartment, whether that could be going from an actual home environment to a nursing facility. A lot of these kind of go into play, sometimes starting, sometimes finishing. Our next slide, this is our big kind of elements of what a good death would be. You have your physical comfort, your spiritual, and your emotional well-being. And as you can see, right in the middle is that perfect trifecta of all of these. And I'm going to go on a little spin-off of this one. Another nice thing that we like at Amedisys, we like to do with this good death is what matters most. When Shane, our nurse, does the actual hospice admission, he'll ask loved ones, he'll ask the resident, what matters most to you? A lot of it's comfort, music. We had one gentleman say watching the Phillies win a World Series. Last year we had a resident that came on services at the beginning of the year that he wanted to see the Eagles win the Super Bowl. They won the Super Bowl. I had a really good hockey fan, which I play ice hockey, and she wanted to watch the Flyers win the Stanley Cup, which I'm not sure how that's going to work out, but we want to make sure that it's a good death. I saw one of my grandparents go through not a good death when I was a little kid at home. So that's why I got into hospice. Is I want to make sure that this is a special time, and I want to make sure if there are any barriers to a bad death, we can certainly get something that is perfect. Again, along a lot of the hospice services, I think I'm pretty biased because I work for the company, but our team is great. We have a team approach. Pain management is one of our big things. We don't want anyone to be in pain. I don't want to be in pain when I come home from hockey and my joints hurt. I know that there is more pain, when that transition starts to happen. A lot of this social support, emotional support, our social workers can tackle. We actually just had a resident come on to hospice services yesterday where we have social work already involved. And the big piece at the end, the education. And not just education on the dying process is what we like to do, but we like to educate before, during, and after. There's always going to be questions that come up. There's always going to be new things that come up where myself, Shane, our social worker can certainly educate and clear up any of those questions and just what this process is going to look like. Now, sometimes we don't have that crystal ball to see when it's going to happen, but we do have a lot of tools that can kind of gauge and see, what the trajectory is, so we can be ahead of the game. And that concludes just the death and dying part. This is a nice little slide that I kind of found. Just kind of hits home a little bit, especially in today's world. So yeah, again, any questions, we can certainly tackle those and get squared away.
Your previous slide mentioned non-pharmacological approaches to pain management.
Mm-hmm.
I can't think of any non-pharma approaches to pain management. Might you mention a couple?
Absolutely. So what we like to do in the non-pharmaceutical ways, there's music therapy. That's one of the nice things, music therapy. Sometimes it helps, sometimes it doesn't help. What it's more that non-pharmaceutical is just taking all those medications away. Sometimes what we see with patients with dementia, sometimes, again, if you maybe throw them into a bathtub, that's not going to go well. A lot of like warm bathing, like bathing in like actual bed, sometimes that kind of soothes as opposed to pain medications. If there's any anxiety, if again, we see it with dementia patients where they're in that room all day and they just need some fresh air. Taking them outside is something that is crucial, and I think probably sometimes 10 times better than giving someone anxiety medications and hoping it works. Take them outside, change up the environment just a little bit, let them get some fresh air, let some sun hit them. That's a perfect non-medication way of helping.
Susan, back here.
I had power of attorney for health care for a friend who was dying, and he lived at home, and it wasn't really convenient for him to try to arrange care for himself. So he went to a independent living facility and had hospice care, but he also had round-the-clock caregiver.
Mm-hmm.
And I really want to point out there's a difference between the hospice care and the round-the-clock caregiving, so that the caregivers do what caregivers always do. They bathe, they get people up. The hospice care was really good. The people who came were excellent, but there was still the need to organize meals, to organize people's life on a daily basis.
Mm-hmm. Absolutely. Yeah, there's that added supportive care, like the gentleman mentioned. It's 24-hour care, so it kind of works in hand with that hospice team. When that hospice team is not there, it's usually non-medical, so they can help with any bathing, cleaning, anything like that. They can't really give any medications, but it's a good way to have that extra support involved with that hospice care.
Mark, do you have the mics back there? Ken, there's a question in the back.
I have a question.
Okay, well then.
Has there been any thought about combining therapy with hallucinogenic drugs to help people get over the fear, anxiety of death?
We actually, not necessarily in nursing facilities. I think there's some policies behind that, but actually we have, I've had a couple of patients that have been at their home that along with the hospice medications, they actually have medical marijuana as well that they kind of tack on board. That's the craziest thing that I've seen, but nothing like super crazy. Just the actual medical marijuana along with now hospice cannot prescribe that. It'll have to be, maybe a primary care physician or something like that that would be okay with prescribing that. But it doesn't go against hospice. That's totally fine with us. No, that shouldn't be an issue. It's something that again, a lot of the states are legalizing it, but it's something where it can be used for pain symptoms. So it's, again, obviously used in the correct way and right way. That can be totally fine.
So could you say more about the box there says support psychosocial, emotional, and spiritual well-being?
Mm-hmm.
I'm thinking, does this involve things like a visit by a psychotherapist? Does it include visits by clergy, in which case you probably would have to arrange for your clergy person, wherever they are, to come in? It seems like something that would be very valuable, but it also seems like something that could be either costly or difficult to arrange, or both.
Costly or difficult, I haven't heard of any costs in the past. Justin is our chaplain, so he has a lot of connections within the community. We have in the past had special requests for Catholic priests to come in. So that is something that, our chaplain has connections to the churches within the area. If there is a preference on a chaplain or a priest and that you want us to contact, we can certainly do. We've done that in the past. If there is ever a psych physician that needs to come in, what we'll do is we'll talk to the nursing facility or maybe talk to the physician and consult that psych doctor to come in. Again, that's not an issue at all. But yeah, we had priests come in, chaplains come in from the outside and kind of give one last blessing. That we can accommodate to that.
So is the psychosocial part more along the lines of somebody on your team who is skilled in that area?
A little bit of both. A little bit of both. We have our social workers that have their degrees within that social work realm. And if worst case scenario, I do know there's a psych doctor on the Bishop White side. We can always consult them in as well. So someone with that background can certainly help out.
Hi, can you tell me, hospice covers 5 days a week. What happens in the weekend to the hospice patients?
Very good question. So what we do, hospice doesn't stop on that Monday through Friday. What we do in a hospice world is on the weekends, our CNAs, our certified nursing assistants, they're there that Monday through Friday, along with our nurse. They give that extra care. On the weekends, what we utilize our registered nurses. That way they can do a little bit of everything. They can do the CNA work, if there's any bathing, cleaning, anything like that. They also will tackle that nursing job where if there are any emergencies that, that specific resident maybe need to get sent out to the hospital or maybe needs a medication change. That way that nurse can talk to that physician right then and there, as opposed to maybe a social worker is available on the weekends, but maybe a CNA, it will have to be kind of whispered down the lane. We try and shrink that care to having a nurse on the weekends, just to speed up that emergent needs if there are anything. But yeah, to answer your question, it's that Monday through Friday social work team, the whole army, and then on the weekends we have 4 nurses that are available that makes rounds. They'll still see our patients on the weekends. If there is ever a need during the week or Friday, Shane's like, hey, we need to check out, Mr. Bob, he's not doing so well. A nurse will see him on Saturday or Sunday. So they will get that care on Saturday and Sunday. Mm-hmm.
One thing that was not mentioned, and this would come into play when you are in your own home, would be pets.
Mm-hmm.
I was with my brother-in-law. My sister was in denial.
Okay.
She was not by his bedside. We had to encourage her. But she had 2 cats. One spent all her days with him for months.
Mm-hmm.
And when he did die, I was there. And I'm the only one that I could get the cat off the bed when they came to take the body.
Mm-hmm. Yeah.
And I have my cats written into my advance directive.
Hey, that is perfect. Animals. We very weird. I shouldn't say very weird story, but we had you kind of hear the cats and the dogs. We had one gentleman that liked reptiles. I'm not a big snake person. I did not get involved, but yeah, I mean that's not a problem. So cats, dogs. I have 2 dogs at home, so yeah, if that is something that that their loved one wants to incorporate them in that care, they can certainly do that.
Well, I'm walking the mic over to that corner. Can I ask a question about narcotics? Are the nurses at Bishop White Lodge allowed to dispense palliative sedation?
Yes. Yes.
So everybody's okay. There's never going to be an hour in the day when I'm in pain and distress.
There shouldn't. So what we do when that initial resident, whether home or facility, comes on to hospice care, Shane, our nurse, is probably even before that looking at all the medications. So when that initial evaluation sign-on happens, we are placing the recommendations to the Bishop White team. Shane is talking to the nurse practitioner and our medical doctor to get all these medications all situated. From there, they usually will order it through their pharmacy, and it's usually delivered that same day. With hospice, there is a comfort kit every patient gets. You don't have to use it. You can certainly use it. With that comfort kit, there's some morphine, there's some Ativan for anxiety, and then there's also Zofran as well for any nausea. And that's every patient gets that. So that's something where, again, we don't want anyone to be in pain. That's something that we get tackled right then and there. Yep.
Question, when someone is at home, when the patient is home, how do you manage that coverage, like over the weekend or in the periods when someone is not around?
Sure. In the home setting, sometimes what we've seen in the past, there are some family that will kind of fill in, and that's totally their wishes. Say, hey, you know, I don't work on Saturday, Sunday. I can certainly help out. What we do, regardless of if the family has some support in place, we always make a visit. We would rather be safe than sorry. We see someone on a Friday and they're totally fine. We don't know what's going to happen on Saturday. We don't know what's going to happen on a Sunday. So a lot of our critical patients, that every day we have meetings, but a lot of our critical patients, even our moderate patients, we make sure that they are good to go on Friday if there's any medications that need to be refilled. But what we'll do is we'll still tack on a PRN visit, an as needed visit, just to make sure they're doing okay. Whether it's a hour visit or whether it's a stop in, hey, if you need anything, please give us a call. So we still do that. Yep.
So it would be an in-person,
yep,
not somebody calling.
Yeah. Sometimes we do get call-ins where it's a loved one saying, hey, I'm not sure whether to take Tylenol or Advil. And they're like, we don't need someone to come out. But most times, if there's a need, we're physically going to be there.
Yeah, I meant more you're being called. You're, how do I put it? Not being giving the call to us.
Yep. Yep.
When we need it. So it's more a question of if we need it, we can ask for it. But on the other hand, they should be checking in with us.
Absolutely.
Okay.
Yep.
Thank you.
Yep. Absolutely. Yep.
Hospitals typically, when are taking care of patients, say, who are financed by Medicare, are often choosing to be accountable care organizations. And they have various measures of what is good from the point of view of Medicare. Is the hospice procedures that you were working with Amedisys, is it an accountable care organization? And if it is, what are the criteria that are used on the part of Medicare to evaluate what's taking place?
We do. We work with a lot of ACOs. Part of our big main hospitals within this area, we work with Chestnut Hill Hospital. We work with Thomas Jefferson. I personally work with Thomas Jefferson Hospital. We work with Fox Chase Cancer Center. Jefferson, they have Sidney Kimmel, which is their cancer center, and then we have Temple as well. So for the ACOs, what they normally do is they look at how many patients that hospitals are referring to us, and we bring on our services. So usually with hospitals, even nursing facilities, what we like to do and what hospitals like to do is they like to discharge as soon as possible. Like, we need it done now. So actually at a lot of our hospitals that I cover, we actually have a nurse that is kind of on standby there that can go speak to that loved one, speak to that patient right in that hospital bed, chat with them, go directly to the case management or social worker and say, hey, this person's good. What medical equipment do we need? We can get that delivered to the home. And most times we usually get that patient out of the hospital that same day or that next day, just to avoid that hospital-acquired death where it gets dinged on the hospital. So we know hospitals work fast. So that's how they kind of gauge. And of course, the hospital-acquired deaths really ding them. They get it's a whole process. So yeah, we make sure that when we are getting referred by an ACO, that it is done quick and to get them out.
So you are not an ACO, your clients are?
Yes. Yep.
Thank you.
Yep. Mm-hmm.
Well, I'm not sure that you've made it clear enough about what services occur at home, because it's not, it's not hands-on taking 24/7, taking care of activities of daily living.
Mm-hmm.
So I don't know if that's come across that clear. And at home, to have home hospice, somebody has to be there. Another member of the family has to be there 24/7.
Mm-hmm.
So I I'm not sure you've clarified
Yep.
what services hospice does and what services the family and patients still have to provide.
Sure. Sometimes with that home hospice route, we get a lot of families that are okay, able, healthy enough to care for their loved ones. With the hospice at home, what we like to do is we like to see those home patients, again, just like we do in nursing facilities throughout the week. We have the CNA go in, we have the social work go in, chaplain. We have volunteers as well, whether the volunteers will come into the facilities, they'll go into the home as well. What we primarily see in that home setting is the families they like the hospice team to come in. When that hospice team is there, we'll provide that care. A lot of those families do like to, provide for their loved ones. I know my family did it. If there are ever times where maybe someone at home can't fully take care of their loved one, we chat with the families, say, hey, how is that home setting working out, if there is any help. Sometimes that is when that kind of added extra 24-hour support kind of comes into play. Some families wish that, some families don't wish that. But a lot of those home patients we kind of keep on the radar as well, just because, maybe spouse has also a disability or can't care for them as well. Sometimes sons and daughters, grandkids will kind of come into play. So there's a lot of factors that go into that home care. And we want to make sure that if someone is at home getting hospice, they have that adequate care at home. We don't steer away if someone, can't accommodate to that home, home support for care. We want to make sure that care is in place. So we'll help them out, whether it's added visits during the week, whether it's, visits, twice a day, spreading those nursing visits out, maybe in the morning and having the CNA come in the evening time. We try and work to what works best for them, but also, want to keep in mind of what those wishes and wants are from that family.
We have time for one more question.
Okay.
So the question is your organization for profit?
That's a good question. Putting me on the spot here. I would imagine we used to not be, but with United Healthcare, because we get our money back from Medicare. We have to follow their guidelines. Medicare pays everything at 100%. That's a good question since we're going with United Healthcare. That's a good question.
There's certainly a for-profit by United Health.
Yeah.
And they're for-profit.
So yeah, I would imagine. Because I know prior to this we weren't affiliated with any insurance, any United Healthcare, anything like that. So now that this is taken over, that's a good question.
But you're not noticing any changes, you said.
No, not that like I said, there's been 3 hospice in the South and 1 home care that they were kind of taken over by another, and like a third party. But within this Philadelphia area, we're still the same.
Okay, now I'm standing up here. We'll have lots of time to talk about this. We've got some nurses, some doctors, some healthcare committee folks who'll be here around to answer the questions that come up next week's Monday, Tuesday, Wednesday, Thursday. Okay? Look, I'm trying to remember to use the forum to post these things online. I send you out in the morning with a link to the simulcast. If you can't get here on the simulcast by 11, it's recorded. And report is, they're coming through pretty well. Who was it that said that to me this morning? Oh, it was Marianne. The audio is great, and Ed's done a fantastic job making this technology available to us. And Michael, thank you so much for